I'm presenting this video to show the advantages of intraoperative OCT in the sweeping technique for Dsaek adhesion. The first step of Dsaek naturally is stripping of the Dsaek membrane. OCT can be helpful in this step in showing where Dsaek has been effectively removed. Next, air is injected into the anterior chamber and the space left between the Dsaek graft and the host cornea is evident. The surgical view makes it seem that the graft is well opposed. In the past, I would stop at this point. However, the intraoperative OCT shows that given this graft is less than 100 microns in thickness, there is at least a 200 micron space remaining between the graft and the host. Now, sweeping over the host cornea with a 30 gauge cannula is performed. Even with only 2 passes, improved apposition of the graft can be seen. Here is a repeat of that sequence and the continued sweeping in multiple directions that I performed following those first 2 strokes. Of note, even with substantial depression of the host cornea, the donor becomes more tightly attached rather than dislocating. In this second case, I'll show the Dsaek steps beginning with the insertion of the graft with the Busen glide and the tan forceps. A suture is placed to close the wound. The AC maintainer is removed and a small peripheral iridectomy is constructed with the tan forceps and Van Ness scissors to avoid postoperative pupillary block. The OCT shows the free-floating graft. The anterior chamber is filled with 100% air, which is left in place at the conclusion of the surgery. At this point, the reverse Sinski is used to center the graft. Here in slow motion, the OCT shows the donor sliding along the host cornea. This maneuver does not result in increased apposition or dislocation of the graft. Since some air is lost in this maneuver, the anterior chamber is again fully inflated with air. Here again, our microscopic view makes it seem that there is good apposition of the graft, and many would find it acceptable to stop at this point. Yet, there is a significant space between the donor and host that is only visible on OCT. This has convinced me to use a sweeping technique with a 30 gauge cannula on all of my Dsaek procedures, even when I operate in a location where the OCT is not available. There are many instruments that can be used to achieve a similar result besides a cannula. Even though my dislocation rate was low before, this maneuver has led to a further decrease in my dislocation rate and has influenced me to promote it to other surgeons. Thank you.